packet is the attendance report. That's attachment 3A. Just as a friendly reminder, if you missed 2 or more consecutive meetings, the Bureau will reach out to you and confirm your desire to stay with the committee. Moving on to the vacancy report, we have no current vacancies. And for item C, the 2025 meeting schedule is attached in the agenda as well. So please take a look at that to sort of plan ahead for future meetings. Moving on to the Bureau report.
Yeah, I'll get us started. Hi, I'm Nicole Witt, Assistant Director of Public Health Preparedness. Just an update on our recruitment. So we continue to recruit for a Bureau Chief for our Bureau of EMS and Trauma System. That is actively open. So if you know anyone that is interested or qualified, we definitely would love for you to encourage them to apply. And then I'm going to turn the rest of the updates over to Julia as we're all within the service section.
Good morning, everyone. Julia Vincent, services section. Just a couple of updates. First of all, we are working on our operational plans for 2026 for our strategic plan, so that we can continue to work on implementing the strategies that we have written down in the strategic plan for EMS for children. The MARC program has recognized 6 EMS and fire rescue agencies, so that's an exciting milestone as we are that's meeting a performance metric for the National EMSC program. We also continue to have the neonatal resuscitation program training available for naloxone leave behind. We are up to over 60 agencies participating and still onboarding agencies for that if you're interested. For SHARE, a couple of updates. We are working on transitioning our current platform from SADR for the hospital data entry to REDCap. So this is upcoming within the next couple of months, and communication will be going out to hospitals. We are also very near to getting our 2024 report done. We have collected all of the information from hospitals and EMS for the year 2024 and have been able to link the data there. So we should have a report soon. So that's very exciting. Also with the update to REDCap, we are moving towards simplifying the data form so that we are in alignment with the National CARES program. And then also for SHARE, for the PEEP data quality, we have been sending out reports monthly. So if you have any questions about SHARE or PEEP, you can reach out to Adam Rodriguez or Ann Foster. And then I just wanted to just give a shout out. We had our EMS and Trauma Awards ceremonies back at EMS Council and STAB in May, and the list of those award winners are on our website. And then lastly, I'll just mention that for the trauma registry, the state trauma data repository is not quite ready for Q1 data submission, but Chris will reach out when that's
And I just wanted to highlight quickly the naloxone leave behind program. So a huge thank you to all the agencies that are participating. So we currently have 62 agencies in the state, but I think what's really impressive is that 25% of all of our EMS providers in the state have completed the training. So that is really a pretty amazing numbers. I don't think we thought we would get that high. So almost 25% are currently trained in the program at a statewide level. So a big thank you. And then a reminder, if you're to your crews, if they give a kit out and they've forgotten to scan the QR code at the time, the QR code is the same across all kits. So they can go back and scan any QR code. We asked for very minimal data elements. This actually came up at kind of one of the NSEMSO meetings, and they really were interested in how we did it in Arizona. We said, we have a single QR code. We want your agency and zip code. So hopefully for the user side, it's very simple to import the data, but just a reminder to them, if they forget at the time they hand the kit out, they can still fill that out to the best of their ability. So big thank you to everyone who's participating in that.
Is that it? Wonderful. Thank you guys very much for the updates. We will move right into our discussion and action items. The first one is to discuss, amend, and approve the draft minutes from March of 2025. Do I have a motion to discuss? Shelley has them up, and they're also attached in your agenda packet.
Sorry, writing that.
Yes.
I'm going to approve. This is Jason.
I'll second.
Okay, any discussion from the group at all? Hearing no discussion, I will move to the vote. So all in favor of accepting the meeting minutes, say aye.
Aye.
Still.
Aye.
Any opposed? Any wishing to abstain? All right, motion passes. Moving on to item B, to discuss, amend, and approve the draft training for STRs for medication-assisted intubation or RSI. That is attachment 5B in your packet. And I will be happy to kind of walk through this. Thanks in large part to Matt Shaw, who provided the bulk of the background for the thing. Oh, a motion to discuss.
So moved.
Thank you. Move too quickly. All right, so we will move to discuss this one. We have in here, we just move along the slides. There's some basic anatomy. Obviously a very pre-hospital focus to this training. So RSI challenges. So obviously, we touched on these throughout the training. So much of this has to do with proper patient selection, dealing with physiologic and anatomic difficulties in intubation, and then very heavily focuses on resuscitation before intubation. So multiple times throughout the training, resuscitation and making sure that you have the right patient selected to perform RSI as mentioned. And then we kind of list through some of the preparation. Positioning and pre-oxygenation, how to perform those specifically. Apneic oxygenation, how to perform that, and talking a little bit about the importance for apneic oxygenation and preventing desaturation, and then moves into the paralysis and paralytics used with a little bit of information about those that we have access to in the drug box. So there's a little bit of the drug reference sheet for each of the medications, including ketamine. And then using depolarizing versus non-depolarizing paralytics. And then a little bit about each of those. Again, a drug sheet with dosing references as well. Indications and contraindications. And then the procedure itself. The number of recommended attempts, what to do if you have a failed airway, and some specifics about waveform capnography and the need that with post-intubation, and then going into post-intubation management again, and then what to do if there's a complication or a failure. So fairly straightforward. And that's at the end of the slide deck. So any discussion about any of the content within this slide deck?
Listen, Jason, this looks really good. The only thought I had, is there anything about blood pressure management and potentially push dose pressors to make sure that their blood pressure's adequate before they push the paralytics?
Yeah, so we have one slide, I believe it's slide 10. Yeah, that talks about resuscitation before intubation, which includes pre-oxygenation and addressing any hypotension, which includes IV fluids to have those running, and then have it ready, push dose epi and ready for administration before you do your intubation. So as part of the resuscitation process to have that prepared.
Perfect. Thanks.
Okay, yeah, you're welcome. Thank you, Matt.
I just wanted to commend the group. I think this is a really well done training PowerPoint. So thank you for everyone putting this together. This is a great resource for all the agencies that are doing RSI.
Yeah, I mean, it's very straightforward. You could add things to it, put videos in, and it kind of has a lot of information in it. So yeah, thank you to the work group for all of your input. Any more discussion Any concerns with any of the information? Do I have a motion to approve?
So. Second.
Thank you, guys. All in favor, say aye.
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 Any opposed? Any wishing to abstain? Okay, motion passes. Moving on to item C, discuss, amend, and approve draft training for EMCTs on children and youth with special healthcare needs. That's attachment 5C. Do I have a motion to discuss? Thank you, Matt. Who did that? That's Sandy? Might have been Sandy. Thank you, Sandy.
Yeah.
Okay, so we will pull this one up here. I think I have Chris Gilbert on here to talk, but I don't know if there's anyone else from the PACES committee that would like to speak to the deck. If no one's here from PACES, I can run through. This slide deck was put together as part of a work group to address some of the needs and training for children that have special healthcare needs. There are a couple scenarios that start out the case. So there's 3 different scenarios related to children with different healthcare needs. And then the rest of the slide deck goes through some specifics about things that are maybe commonly encountered and not commonly understood. So we'll kind of scroll through. There's some data and demographic information. Information about talking to parents and caregivers about their knowledge about the children's baseline needs, patient communication, talking a little bit about specific medical history you may want to get from the caregivers and where that information also might be located in the home, medical alert stuff. Some of these children might have specific supplies and an emergency plan that they may have written up to help assist EMS. Goes into some stuff about transporting and patients that might have some anatomic abnormalities. Transport destination decisions, talks a little bit about that some children might obviously have a particular destination based on very specific healthcare need. And then touches on some specific equipment issues that some of these children might have specialized equipment in the home that needs to go with them to the hospital. And then several slides about trach and vent management and troubleshooting. Indwelling lines, information about feeding tubes, shunts and urinary catheters, and then a little bit at the end about neurodiverse children and some behavioral and sedation considerations as well. And then it ends with some additional research. So I know the PACES group had spent some considerable time trying to cut this, what was initially a large amount of information down into something a little digestible. As I went through it, I did have some specific comments back to PACES related to some of the content. And I don't know if anyone else has looked through this yet. There is, to me, quite a bit of information in here that is fairly beyond the scope of practice of a general EMCT or paramedic. And so I think most of my concerns relate to that content. And it isn't just on one slide. I think it's kind of throughout the presentation. I think there's still a lot of information about clamping central lines and aspiration precautions and some things that aren't explained in here and how that they could be performed in the pre-hospital setting. So some of it's just practical. I don't know how you could possibly perform some of this in the pre-hospital setting. And then some of the stuff about the neurodiverse children and some of those things I think are very helpful. But some of the ventilator troubleshooting, stuff about central lines, like those stood out to me as being much of it fairly beyond the general scope of practice. And so my concerns relate a little bit to that. So I don't know if anyone else has other comments.
I can address that. So that concern was brought up during the work group meetings, and what was recommended was to put a scope of practice slide at the original, so that everyone is on the same page knowing what they can and can't do. We just wanted to have this inclusive from basic EMT all the way to critical care paramedicine, and making sure that all concerns are addressed for this unique population. So I hope that that helps to address those concerns.
I think so. I did see that initial slide in here. I think that I don't think that the general practitioner is going to reference scope of practice. They're going to follow their protocols. And much of this would not be outlined in any specific agency protocol. So even if we reference the scope of practice, if it's not within their protocols to do some of these procedures, they're not going to be able to do them anyways. And so I don't know that that's particularly helpful, especially when we talk about things like clamping central lines, and we don't really explain how to do something like clamping a central line. It's not something that we train our providers to do. And I don't even know what equipment they would use to clamp a central line with in that setting. So I think there still is just a lot in here that to me isn't explained enough to be able to be practically implemented in a pre-hospital situation. That would be my concern. I don't know if others have read through enough of it. I do think we could address it potentially, and maybe work with the education committee to kind of go through the specific issues that might be a little outside of scope.
And I think maybe the focus should be a little more on the EMT and paramedic response, just because critical care paramedics are less likely to respond in a 911 situation. So it's typically going to be in a facility, and they have a much higher level of training. So I think a lot of this for critical care paramedic, this is just their bread and butter. This is what they do all day, every day. So I think for them, this is probably almost a lower level of training than they have. But I think to focus the education really specific on EMT and paramedic, just because most of our education curriculums are focused on the 911 response. So I think that may help address some of what Amber's referencing and making sure that this is kind of usable. Because I think there's a lot of really good information in here, but we want it to be something that an agency can pick up and really use, just because I don't think there is enough of this training out there for EMS. So I think if we can kind of pull out some of the more critical care focused piece, I think that would then make it a little bit more applicable to the general paramedic running a 911 call. And I think that would be a really great resource, because it is definitely a needed education.
Yeah, I think a lot of the stuff about patient communication, baseline history, transportation considerations, that stuff was all really helpful to me. The rest of it, aspiration precautions and things that I don't think that it's not explained how to do it. And I don't know that we would be able to train them to do that necessarily. So those things I do think we'd have to address before we'd be able to push it out at the general level. So I think
I do like the fact that they have put in there under the ventilator troubleshooting that treat the patient, not the machine, which is always a priority.
yes, for sure. I think maybe my suggestion would be maybe having a education committee specific work group to kind of go through some of the specific issues that might be out of scope or not adequately explained. I think might help to address some of these things. That would be my recommendation. But I would need a motion from somebody.
You can make a motion.
So motion to bring this to an education work group session and try to go through some of these specific scope issues.
So,
Thank you, Ben. Second, anybody?
Second.
Thank you, Brian.
Second, Jason.
Thank you, guys. Okay, with that, we'll go ahead and vote on that motion. To form a education committee work group to go through some of the scope of practice issues, so we can present this to a general EMT and paramedic population. All in favor, say aye.
Aye. Aye.
Any opposed? Any wishing to abstain? Wonderful. Anyone wanting to participate with that? Please let Shelley and myself know, and we will get a date on the books to review some of the training.
See some hands.
I was on this to begin with, so I'll.
Yep, no, that'd be great. Thank you. Yeah, and big thanks to the PACES committee. They did put quite a bit of work into putting this together, so we do appreciate the time. Lost my agenda.
What's this one? Volunteer names that captured with Bryant Smith.
Brian. I'll find you some folks. I would include Dr. Munn also. He was on it also from before. Okay, next one, discuss, amend, and approve forming a work group to create the next STR training PowerPoint. Looking at the list, so if we look at the list of things that are still sort of outstanding, the RSI one we addressed today, the outstanding list has a couple things on it that I think are potential next items to discuss. The ones that might be the most used that we don't currently have, I think might be related to maybe the EMT STRs for IV initiation and potentially the ultrasound IV placement. We don't have any training for that. There are some things that we could potentially put together. I don't think they would be necessarily long trainings, but those were two that sort of stood out to me as maybe being utilized more often. The other one would potentially be the use of a transport ventilator. So obviously, some of the training that you do for ventilators is very vent specific. Some of it is very general in terms of ventilator modes, physiology, sedation, that kind of stuff. So certainly, those are the two items that stood out to me as maybe being potentially next on the list, but I would obviously open it up to folks that have thoughts or a preference.
One thing on the list I saw, we have EMT IM, but I think we actually have that covered.
We do, I
Under the
believe.
IM
I think it's in the IM EPI. Yeah,
So
so
that one
it's,
is covered.
yeah, so I didn't mention that one.
But I think we can cross that off the list as completed.
The IV placement stuff, plus or minus the venous blood sampling, which is technically included in there, but could maybe lumped into one training.
You can almost do, because there's EMT IV access, initiation peripheral, and maintenance of non-medicated IV
Yeah,
fluid. So that
exactly.
could
Yeah.
potentially knock out 3. I do see Kyle had his hand up.
Oh, Kyle.
No problem. Thanks. Just for clarification, I love the EMT IV initiation one. I think that's a great one to focus on. I'm looking at the document. Did I miss something, or is there one on NEBS already? And based on the scope, it seemed to be, I was actually having a conversation with Marissa from DHS yesterday. It seems to be some of my providers have asked about it. And when I looked at scope, it looks like the NEBS are in scope without an STR, but yet if you read the fine lines, they need a medical director to add the medication. Is that accurate, or is it a little muddy?
SVN is in scope of practice. I think that is taught in general EMT scope of practice. So the scope of SDR is specific to the skill, which is a little bit goofy sometimes. So the best way I describe it is the scope of practice is the act of doing something versus the drug table, which is medication and medical director would approve for use by their agency.
Gotcha. So they would need technically the STR for the medication or merely a medical director approval for the medication since the SVN is already in scope?
Just medical director approval. Yes, great clarification. So the SDR is only specific to the scope of practice, or like kind of the act of doing a procedure or skill.
Got it. Okay. Didn't mean to muddy the stuff with that one, but that clarifies that. I love the IV stuff and be happy to sit on anything for initiating that.
Yeah, that is a very good clarification, Kyle. So I think that is important just to kind of expand on that a little bit. The way I look at the drug
that door too.
are kind of like a menu of what your medical director will approve for your use versus the scope of practice is kind of what is generally trained in your training program initially as an EMT or paramedic, or the special training required, which is the SDR.
And
So
don't forget.
your scope is kind of what's just out there as your training.
Yeah,
That
it's not for a little bit.
Chester, you can meet you. Oh, you got it. Okay. So the scope is really approved for everyone unless it's STR. That means you have additional training, and then your drug tables are kind of the menu that your medical director can choose for your agency what you're going to give.
Thank you very much, Dr. Bradley, for that clarification. So I'm hearing mostly interest for the several items here that have to do with IV initiation and maintenance of fluids.
Let's add the ultrasound one too.
Yeah, I think we should do them all. Yeah, I agree. All the IV stuff, we can include venous blood sampling. I don't really think there's much to that. But maybe a slide or something, but yeah, I think we can include all this together. So is that a motion, Matt?
It is.
Thank you.
Yes.
Do I have a second?
Second.
Thank you, Brian. All in favor of forming a work group for the IV initiation and maintenance of non-medicated fluids, say aye.
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 Any opposed? Any wishing to abstain? And I think I had Kyle was one that volunteered.
Kyle, I see Chris Gilbert as well. Looks like he volunteered.
And that you said you had some
Yeah, it's some stuff as well.
ultrasound
For the ultrasound.
Okay. Anyone else interested, please shoot myself and Shelley a message. All right. Moving on to the next action item. So we do have this standing list that's in your packet. This is what we were just referencing to keep a running list of when our items were updated. So reference that as you want. Next agenda items to be considered for next meeting. If you have any, please email them to me. And then the last item here, call to the public. That's not the last item. Is there anybody from the public wishing to speak? Hearing none, we will move on to upcoming events. There's a list here, also available on the Bureau website of upcoming events around the state. Our next meeting is November 20th. And hearing nothing else, we will adjourn the meeting. Thank you.
Robin, Sandy, for you.
Yes. She's much better.
Showing me up.